Welcome to Longevity and Aging series. Today I would like to introduce Dr. Shubhankar Suman. Dr. Suman is an associate professor in the Department of Oncology at Georgetown University Medical Center. Dr. Suman's research is dedicated to acute and chronic health effects resulting from exposure to ionizing radiation, with a particular focus on how radiation exposure contributes to cancer development. His areas of expertise cover several critical topics, including radiation stress signaling, radiation-induced carcinogenesis, acute and chronic radiation toxicity, and radioprotection. Dr. Suman recently published a paper titled Senolytic Agent ABT-263 mitigates low and high lead radiation-induced gastrointestinal cancer development in heterozygous APC 1638N mice. So, Dr. Suman, could you start by telling us more about what inspired the study and what led you and your team to explore senolytics like ABT-263 in the context of radiation-induced gastrointestinal cancers?
Yeah, thank you, Dr. Galimov. Thank you for having me. Before going into the detail of the paper, the overall purpose of this paper was to develop a proof of concept. Like if there is some opportunity to use a senolytic or senotherapeutic agent as a mitigator for radiation-induced late effects, including cancer or tumorigenesis. So in past 10, 15 years, we have used this APC heterozygous mouse model, which is a well-accepted mouse model for colon cancer development or colorectal cancer development, CRC. And CRC is like one of the most common cancer type worldwide, and it is the third most common cancer globally, and it is the second leading cause of death by cancer worldwide. So this is a very important area, and having a mitigative agent with radiation is just a proof of concept that any other stress factor which is related to carcinogenesis or colorectal cancer development, it can be lifestyle factor, it can be obesity, it can be diet related, or it can be any other risk factor which can drive colorectal cancer development. These agents may help in that risk susceptible population as well. So this whole aspect is not only limited to radiation-induced carcinogenesis. Here, basically, we are using radiation as a tool to induce colon cancer and then test a mitigative strategy where we are trying to use senolytic intervention. So this is kind of the overview of this paper. And then we also, because I am radiobiologist and we are more interested in studying variety of radiation types. So we have used different radiation types. Some are relevant to population on Earth, and some are relevant to astronauts and space biology. So we are trying to develop a mitigation approach that can be leveraged not only for the population on Earth, but also for astronauts. So these are like wider implications of this study. And the mouse model we are using is just a tool to study carcinogenesis, and APC models are well accepted model to do that.
Mm-hmm. So can you tell a little bit more about this model? What mutation is introduced in this model and what cancer does it represent?
Yeah, so generally APC mutant models, there are many of them. They generally represent colorectal cancer in humans. So they are a surrogate mouse model for human colorectal cancer studies. In terms of tumor development, in mouse model, most of these tumors develops in the small intestine, contrary to what we see in humans, where it develops in colon and rectum. But because of similarity in genetic phenotype or mutations that are required to develop tumors in these mouse model, they are very similar to what we see in human population. And in addition to that, the progression of tumor development, like in human, colorectal cancer starts with a small polyp, and then polyp gets bigger and deeper, and it invades into the tissue. it becomes adenoma, and then it progresses into invasive carcinoma, where it spreads from GI tract to other tissue types like liver or other, spread into the other body organs. So we don't see any invasive phenotype where it spreads from intestine to other tissue type in mouse, but we do see the progression of polyp to adenoma to carcinoma to invasive carcinoma, and we can track all the histological parameters associated with cancer development, along with APC mutation and other gene mutation which are prevalent in human colorectal cancer. So that makes this model very relevant. And in past, this model, not only APC 1638, but other APC het model like APC main, we have also used these models for development of risk assessment approaches, like where we try to screen agents or radiation types and try to assess is there a risk for colon cancer development after those agent exposure to those agents. And we can also do preventive strategies and test some preventive agents
Mhm.
which can't be done in human population. So we can screen new agents using these mouse model, and even there are some in vitro approach where you can take out cells from these mouse model or tumors ex vivo. You can do high throughput screening of agents. So
Mhm.
this model is like very relevant in the terms of uh, cancer biology studies as well as to develop preventive agents that can be translated to humans because of the similarity in tumor phenotype and histological parameters.
Mhm. And my understanding of cancer biology is quite limited. So, but what I read about human colorectal cancer, it starts, as you said, with adenoma and then develop into adenocarcinoma, right?
Yes,
But
yes,
in the paper, I noticed that you count separately carcinomas and adenomas.
yes.
Means that adenocarcinoma is not developed in mouse model.
So whatever we are saying here is all carcinoma type we are counting as carcinoma. So that includes in situ carcinoma and full blown adenocarcinoma. So we can't really, because the number of mouse and sample type is limited. So we just wanted to have a two category where we are scoring all the non-malignant one as adenoma and all the malignant tumor as carcinoma. But we do see invasive carcinomas where the tumor cells basically they penetrate into the muscle layer of the intestine. So that type of tumor we classify as adenocarcinoma. And we do see those, but we are classifying all the in situ carcinoma and adenocarcinoma together as
Mhm.
carcinoma. So this is just like presenting our work in that way. So it is like easy to understand. Instead of having like three, four different categories, we have two category: malignant one and non-malignant one.
Mhm. Cool, thank you. And you use two types of ionizing radiation in the study. So can you tell more about that?
Yeah,
Like,
so ionizing radiation is just a energy deposition, like in terms of radiation, where it can ionize molecule where it hits. So let's say a radiation passes through a cell or a tissue type, and it creates ionization event inside the tissue. It can be ionization of water, it can be ionization of biomolecules like DNA, protein, and lipids, uh, and that have enough energy to cause that ionization. But in addition to having the ability to ionize biomolecules, there are different types of radiation based on their physical property. So the common photon radiation, which is characterized as low LET radiation, like photons, X-ray, gamma ray, that are commonly used on Earth for diagnostics as well as radiation therapy purposes. These are low LET radiation. They are considered as packet of energy. So they just have energy. They don't have any inherent mass.
mhm,
So when they hit, their ionization is more diffused compared to the other high LET radiation, where basically any atom, any element or any atom can be accelerated at the speed of light or more than a speed of light, there it basically becomes a radiation with mass and charge. So what happens, like let's say we have used silicon radiation here. So a silicon atom is basically stripped out with all the electrons from the silicon, and this is a silicon nucleus, which is inherently a positively charged particle because all the electrons are stripped out. And then this nucleus of silicon is accelerated at the speed of light, and it becomes a radiation with energy plus mass because it carries the mass of the atom of silicon nucleus. So then when this type of radiation hits to the biomolecule, it passes through the biomolecules, it basically not only causes dense ionization pattern, but it also creates secondary radiation particles. So it is much more damaging, and the damage is much more denser. Particularly, we have done DNA damage studies with two different radiation type where we have compared low LET or gamma rays versus high LET like silicon radiation. And in those studies, we clearly see the density of damage is so much that it is very hard to repair after silicon or any high LET radiation compared to low LET gamma or X-rays. At the same time, these radiation types they differ in their biological effectiveness to cause damage and subsequent effect like cancer development or tumorigenesis. And in our previous studies, we have compared different high LET radiation type with very low LET to very high LET range, a spectrum of LET. And we found that this high LET radiation is much more effective. In certain cases, like silicon versus gamma, it is 10 to 12 times more effective in inducing adenomas and more than 40-50 times effective in causing carcinomas. So these events are much more intense after high LET radiation exposure. So in this paper particularly, I would like to point out that we have used 2 gray of low LET radiation and we have only used zero point 0.1 gray of silicon radiation.
Mhm.
And these results are comparable. Like in terms of adenoma numbers, if you will see, 2 gray of gamma radiation is causing average adenoma numbers like around 10 or so, and zero point 0.1 gray of silicon is almost equivalent to like 7 or 8 adenoma per mouse average. So it is very close in terms of effectiveness. So this is called in radiobiological terms, we call it radiobiological effectiveness, RBE factors. So it is approximately 10 to 12 times higher for silicon radiation compared to low LET gamma radiation. So that's why in this paper we have plotted these two studies separately, like low LET radiation studies in a separate result and high LET in a separate result parameter because they are not comparable in terms of dose. There is a large gap in the dose, but we do see effectiveness like even 10 centigrade or zero point 0.1 gray of silicon radiation results in very higher frequency of adenoma and carcinoma numbers. That basically indicates higher effectiveness of these radiation type.
Mhm. But in terms of mechanisms of carcinogenesis, do you think these two different types of radiations similar or they differ?
Uh, it is not mechanism as such is not different in terms of pathways. Like when we talk about beta-catenin pathway or APC mutation related changes, mechanism is not very different, but there is a differential response. So let's say uh, very low dose of high LET radiation can alter these pathway effectively, whereas in case of low LET radiation, you need to get certain dose to alter these pathways. So there is a differential response in terms of dose, but we do see like most of these pathways are even altered with low LET radiation, but you need to give higher dose
Mhm.
of low LET radiation to induce that kind of biological effect. So that is
Basic-
the That is the difference. So we do see DNA damage after low LET and high LET, but if we give same dose of both the radiation, we do see higher DNA damage, higher mutagenesis, higher changes in transcriptome, higher changes in metabolome, higher inflammatory response, and more noticeably, we do see higher accelerated aging in mice. So let's say we give like 50 centigrade of low LET radiation and 50 centigrade of high LET radiation. There is much more premature aging phenotype in high LET radiation
Mhm.
compared to low LET radiation.
Uh-huh. And you obviously studied the effect of Senolytic to prevent cancer development in this study. What is the role of senescent cells in carcinogenesis and particularly senescence-associated phenotype?
Yeah, so this is an emerging area, and previously it was thought that senescence or stress-induced senescence is preventive against cancer development. But especially in case of solid tumors like gastrointestinal or colonic tumor, in population we know that solid tumors are tend to be have higher risk at a later age in life. So, in compared to radiation-induced tumor like leukemia or other tumor type, lung, GI tumors, and other solid tumor types, their risk increases with age. And in general population also, who are not exposed to radiation, older population, they are at higher risk of developing these tumor types compared to young ones. There are studies where they have compared like young cohort with the older cohort, and there is a significant difference, like at least 8 to 10 times higher risk with the age 60 plus in human population. And at the same time, in atomic bomb cohort study from Japanese atomic bomb studies, they do see increase in colorectal cancer and other solid tumor types in radiation exposed population, and it is much more higher as they age. So there is some aging component, and it is now very much apparent from mouse model studies that accelerated aging is playing important role to drive these tumor types and increase the risk of tumor development, particularly for the colorectal cancer in our studies. So accelerated aging or even normal aging, we do see increased number of senescent cell, not only in your GI tissue or like particular tissue type where you are looking for tumor development, but overall aging phenotype, like accumulation of senescent cell throughout the body. So, what we have not addressed in this study is how systemic SASP is related to tumor development and how much senolytic agent is affecting systemic versus local SASP phenotype. So these things I think we need to address in future studies where we need to understand how local tissue phenotype, local tissue microenvironment, tumor microenvironment are affected by systemic changes in um, all these senescence associated secretory phenotype factors.
Mhm. But what you see at the moment, so in this paper, you see that this particular senolytic ABT 263 prevents tumor development in this mouse model, both induced by high and low lead, right?
Yes,
And you also show that uh, this senolytic effectively removes uh, BCL2 family protein expressing senescent cells, right?
yes.
And yeah, so can you tell more about this kind of findings? Uh, yeah, what is the main message of this paper?
Yes. In our earlier study, we compared low LET and high LET radiation studies in wild type mice, where we compared low LET and high LET exposed wild type mice at three different time points. So we did like 1 week, 6 month, and 12-month post exposure. And we found that in the intestinal crypt, where the intestinal stem cell reside, specifically we see a stem cell senescence after high LET radiation exposure, which was much greater compared to low LET radiation exposure. So we found that in a stem cell, which is the proliferative component in the intestinal tract, and it is believed that most of the GI cancer are developed from altered GI stem cells. So GI stem cells are considered cell of origin for colorectal cancer development, and senescence induction in a stem cell is also indicative of some kind of perturbation in those cell types. So it may be due to like some of the cell type they undergo DNA damage, acquire mutation, and then undergo senescence. But at the same time, other cell type who can evade mutation and they can proliferate, they lead to development of aberrant crypt cells and ultimately developing into polyp, adenoma, and carcinoma. But the other cells, which are senescent and sitting there in the crypt, they may acquire SASP phenotype. SASP phenotype means when the senescent cell they secrete all different kind of pro-inflammatory, pro-growth factors. They can influence the development of other cell which is already altered and acquired with the mutation. They can accelerate progression of that polyp into carcinoma. So that is the main aspect of senescence and SASP associated tumor development after radiation exposure. So that study was published in PNAS, I think 5, 6 years ago. And from that study, we thought that it will be interesting to test senolytic agents. So what senolytic agent can do with this kind of changes in GI stem cell or the GI crypt cells. So in this particular study, we use ABT263, which is a known senolytic agent, and it is basically inhibitor of BCL-XL. It also blocks other BCL2 family members, but BCL-XL is the main target for ABT263. So when we looked into the basal expression profile of BCL2 family members in mouse and human intestine using RNA-seq database, we found that BCL-XL is the predominant isoform which is expressed in GI epithelium of both mouse and human small intestine. So we thought that ABT263 will be a good molecule to target this protein. Then, before testing this molecule, we used gamma ray, 2 gray gamma ray to see if there is any effect of radiation on BCL-XL expression on these cells. And we found that BCL-XL expression was particularly increased in P16 positive cells. So we did a dual staining for P16, which is a senescence marker, and BCL-XL, which is a target for ABT263, and we found that there were increased number of P16 BCL-XL positive cell, and at the same time we also found there is increased number of P16 and SAS positive cell that was marked by P16 and IL-6. So we thought that if we use ABT263 and if we can eliminate these cell types, it may reduce tumorigenesis in this mouse model. So in subsequent studies with low and high LET radiation, we use ABT263 and then followed up for number of adenoma and number of carcinoma development. And we found that both low LET and high LET induced tumorigenesis as well as cancer development was dampened by ABT263. The only thing that was not clearly addressed was role of systemic versus local SASP.
Uh, but how are you going to study this difference? And I think in this study, you basically just measured the amount of SASP-related proteins in blood, which is probably a systemic
Yeah.
effect, right? But how can you actually measure local SASP in mouse model?
Yeah, that needs to take like different approach where we can use like organ culture models, where we can irradiate mice with low and high LET radiation, and we can take out tumor and normal tissues from these mice and do organ culture, and then isolate SAS factor from the media of those organ cultures, and that will inform us about the local SAS phenotype. But I think with the accelerated aging, systemic SAS plays the huge role because it is coming from all different tissue types. And in general, with aging, we do see increased inflammatory markers in normal aging population. So systemic factor is likely to play important role, but probably in the adenoma to carcinoma development phase, um, the local SAS factor is much more important. So it can drive uh, aberrant cell into a tumor cell type. But in terms of development from adenoma to carcinoma, both local and systemic SAS play important role.
Mhm. It's very interesting indeed. And as I understand, we don't really know what types of cells produce most of the systemic SASP.
It is again complicated because tumors, like in a bigger tumor like adenocarcinoma, we do see number of senescent cell inside the tumor, and they also acquire SAS phenotype. So uh, in tumors, probably they are self-sufficient in terms of producing local SASP and driving all the epithelial mesenchymal transition and those things from the local SASP phenotypes. But in terms of tumorigenic risk after radiation exposure, probably systemic SASP also play important role.
Thank you. Very interesting. Yeah, my next question would be, uh, so basically you show that you used two types of radiation, and you show that both these types of radiation cause both adenomas and carcinomas, but significantly more carcinomas. Why is that?
Uh, because we are interested in number of carcinoma, which is the real disease, because adenoma is more, most of the time in human population, adenoma is not very important in terms of like lethality or cause of death. Carcinoma is more important. So in terms of carcinoma, if you see, as I mentioned in the beginning, we have two different doses. For low LET, we are using 2 gray, but for high LET, we are using only 10 centigrade. So if you see number of carcinoma with 10 centigrade compared to 2 gray of low LET radiation, number of carcinoma is much more.
Mhm.
Relative number of carcinoma is much more with the high LET radiation exposure, and that also indicates higher risk of colon cancer development among astronauts, because high LET radiation, they are known to cross through the spacecraft shielding in the deep space, and it is known to cause a variety of health effects including increased risk of cancer. So carcinoma development is important because it is much more related to lethality after colorectal cancer development. But in case of adenoma, that can be handled using screening and preventive approaches. So that's why we wanted to compile data for both adenoma risk versus carcinoma risk, where carcinoma risk is much more clinically relevant. But adenoma risk is important to understand the baseline events, like what is happening during the course of tumor progression.
Mhm.
So this was the reason we were interested in profiling both adenoma and carcinomas.
Mhm. And also, I noticed that in the case of highlight radiation, ABT 263 reduced the number of tumors to the basic level, to unirradiated level, but still the percentage of carcinoma increased. So how can you explain that?
Those increase are very minimal, and it is because of the number of mouse we have used for the ABT group, which is relatively less compared to the radiation group. So this is not a like very significant number, but we do see like infrequent increase in carcinoma in that group.
But could it be so that ABT 263 is more effective at preventing adenomas rather than carcinomas?
That's a good question to ask, but as far as I know, um, ABT-263 we have given chronically for 3 months continuously. So in that case, if ABT is just preventing adenomas in unexposed population, uh, it doesn't basically show because this carcinoma numbers are relative to adenoma. So
Mm,
if you see the bar graph, we have two bar graph. One is the black one, another one is red one. And red one represents induced carcinomas.
mm,
So that induction is not very much with ABT, and we still think that there is not enough number to say or conclude that ABT is basically increasing carcinoma, or it is basically not preventing so much from the carcinoma events, but there is some prevention from both adenoma and carcinoma altogether. Like when we talk about the total number, it includes everything.
mhm.
Yeah.
And also, I noticed that in case of high lead eye radiation, uh, ABT 263 basically reduced the number of tumors to the unirradiated level. But in case of low LET, there was still 1.5, around 1.5 increase in number of tumors after treatment. How can you explain this difference?
This is just like basic variability in the mouse model studies, and this is not statistically significant. So that's why we have not given any like a statistical parameter for those bar graphs. So that doesn't indicate that it is a significant change.
Mhm. Cool. And also, I noticed that you studied interleukin 6, you measured interleukin 6 for the case of low lead, but not
Mhm.
for high lead. Do you expect the same effect on interleukin 6 by ABT 263 for high lead case as well?
Yes, we do expect the same thing because with the high LET radiation, we have already published IL-6, IL-8, and many other inflammatory markers that we have already published. So we know that these inflammatory cytokines are upregulated and much more upregulated after high LET radiation compared to low LET radiation. So we have done some experiment with ABT also, and we do see a decrease in these markers even in the intestinal crypt cells. Yes.
So, one thing you mentioned in the discussion of the paper is that you would like to distinguish between SASP coming from tumor cells and from senescent cells. Can you elaborate on that more? Because why do we expect tumors to produce SASP?
Yeah, so in general, like in all the tumor types with solid tumor, what happens is they become hypoxic after they become really big because they don't have enough blood circulation or endothelium towards the core of the tumor. And once they have limited supply of nutrients and other factors required for survivals, these tumors they become some of the tumor cell they die, and many of them also acquire a senescence and SASP phenotype, and they keep on secreting all these pro-inflammatory, pro-growth factors to drive tumor development or progression from solid tumor, adenoma to carcinoma or invasive carcinoma. This is a common phenomena in most of the solid tumors, not only colorectal cancer.
Mhm. Thank you. But as I understand, also any chemotherapy can induce senescence in tumors as well.
Yes, yes, yeah.
And well, let's focus now on the drug, ABT-263. Uh, so what is the current situation with using senolytic agents in oncology?
Senolytic agent are still like under trial as a combination to improve therapeutic efficacy of known drugs. Particularly, the interesting and emerging area is now to use senolytic to improve immunotherapy and immunotherapy related side effects. So, but nothing is approved directly to use as a senolytic for uh, cancer treatment. But there are several trials going on to either improve the therapeutic index of a particular cancer drug or to reduce side effects after chemotherapy or radiotherapy. These are all ongoing studies. There is one molecule called dasatinib, which is also a known senolytic agent, which is approved FDA approved drug for cancer therapy. This is not approved as a senolytic. It is approved just as a cancer therapy drug because it basically inhibits some of the kinases overexpressed in some cancer types. But that drug is also having a senolytic ability. And in addition to that, there is another ABT related drug, which is ABT-199. That is also a approved cancer drug, but with limited senolytic ability. It is the same drug that targets BCL-XL, but the potency for senolytic is less compared to its pro-tumor efficacy.
Mhm. And
So there are several drugs that are basically being tested as a combination or after therapy just to improve symptoms related to side effect after cancer chemotherapy or radiotherapy.
mhm. And in relation to colon cancer, m- am I right that only ABT-263 is currently tested uh, from all other known senolytic drugs?
Yeah, so there are several senolytic drug we are testing in our lab in mouse models, not in clinic, just to see like if it improves radiotherapy associated late effects on the GI tissues, because most of these colon cancer patients they do receive radiotherapy somewhere in the therapy regimen. And because of normal tissue toxicity to the nearby normal tissue in the tumor irradiation field, there are known implications, late effects of radiotherapy, particularly in the rectal tumor treatment. And in that case, using senolytic may help, but we don't have a clear-cut answer right now. We are just trying to test these molecules in that kind of setting using animal models. We do believe that there is some positive impact of these drugs, as indicated in this study. But the main question that needs to be addressed is when to give senolytic agent during the therapy, after the therapy, or in between the therapy, like when you are switching from one cancer drug to another cancer drug. Do we really want to get rid of all the senescent and SASP cells accumulated from the previous therapy and rejuvenate the microenvironment, rejuvenate the immune system, and then use another cycle of chemotherapy or radiotherapy?
Mhm.
So that kind of approaches, they are all in concept, and I think other investigators they are trying these ideas, but nothing is approved so far.
Mhm.
So it is not a standard of care for cancer patients, but there are some reports where it do improve immune cell population and it improves efficacy of immunotherapy related treatment regimens. So that kind of indications are there, but nothing is approved for clinical use right now.
Mhm. And well, you mentioned about different times of starting the therapy, right? When it's better to start, when it's not.
Yeah.
Why did you choose this particular design of your study? So you irradiated mice first, then waited for 2 months, and then uh, give the drug almost every day for 3 months.
Yeah.
So why is that design? Because as I understand, Senolytic should kill senescent cells quite quickly. So
Yes.
why do
Yes.
you need to give them to give
Yeah.
the drug to the mice for every day for 3 months?
Because this was the first like proof of concept study. The start point for the ABT263 was well thought because we wanted to give some time for senescence and SASP cell to accumulate. So we wanted to give these doses like 2 gray or zero point 0.1 gray of silicon radiation and wait for some time to have that kind of effect settled in the tissue type like GI tissue that we have seen before because these changes are progressive. Accumulation of senescent and SASP cell after radiation exposure is a progressive phenomena, especially in the small intestine. We have seen other tissue as well. So this keeps on increasing with time. So as long you wait, you will have more senescent and SASP cell after radiation exposure. But with the limitation of using this APC 1638 mice, we can't keep these mice too long because they do develop tumor and there is like a lot of complication associated with like large number of tumor. They stop eating and their longevity is not that much. So window is limited. So in our previous studies, we have done like 5 month post-exposure, all the tumorigenesis study. So we just wanted to start after 2 months with the ABT263. But why we used ABT263 continuously? Because there are reports which suggest like when you use senolytic for let's say 1 week or 2 week, and then you discontinue the drug, there is again like accumulation of senescence and SAP cell. So we did not wanted to that kind of accumulation due to discontinuation of senolytic regimen. So we just continued throughout the study and then we sacked the mice after last dosing. That was the whole idea. Because in some study we have seen like when they do senolytic treatment using hit and run method where they give senolytic for let's say 2 weeks and then they discontinue the drug for another 1 month, then give 2 weeks like that. They do see senescent cell coming back into the system because what's senolytic does, it just remove the senescent cell. But if there is already enough SASP buildup in the cell, there is a phenomena called secondary senescence accumulation, where SASP factors which are in circulation or systemic SASP, they can again induce senescence in normal cells. So accumulation of secondary SASP happens after discontinuation of senolytic agents. So if we just keep continuing the senolytic throughout the study period, there is less chance of that secondary senescence happening in between our study. So that was the whole idea. But ideally, it should be done in a cycle where you give the drug for like 2, 3 weeks or 1 week, depending on the drug type or drug dose, and then see the effect. But because this is the mouse model and these studies are very expensive to do, so we don't have that much leverage to do like studies in between, like first cycle, then we sack the mice, then we discontinue and then sack the mice. So that kind of leverage is not there. It is because of logistics and expense of the study. But probably that kind of a study is required to address all these questions.
Thank you. Very interesting, particularly to study the dynamics of senescent cells accumulation. Um, let's talk about ABT 263 in terms of off-target. Does it have any off-target in the human or mouse bodies?
Yeah, so ABT263 is basically a very potent blocker of BCL-XL. So its side effects are well known, particularly in the cells with higher expression of BCL-XL, including platelet cells. So it is a very common side effect that was observed even in the clinical trial of this drug, that long-term administration of ABT263 at clinically relevant dose, like where you want to treat cancer patients, they do see thrombocytopenia or loss of platelets, increased risk of bleeding in those patients. And that was one of the common side effect. In mouse model, we did not notice that kind of effect, and not a single sick mouse we found in ABT treatment group. The only thing we observed is slight decrease in weight gain or weight profile of ABT treated mice versus vehicle treated mice. So that difference was there, but we did not see any like rectal bleeding or bleeding of any type. Um, and we do see ABT effect in terms of cytokine profile changes. And that is mostly related to decrease in some of the growth factors like GCSF, GM-CSF, which are basically required to maintain different blood cells, white blood cells. So that kind of observation we also noted in our study, and that data is included in our supplement. So where we have compared control versus ABT group, and we do see decline in these growth-associated cytokines like GCSF, GM-CSF, and these molecules are very important to keep your blood profile normal, like platelets and other cell type in the blood. So there is some adverse effect, but in mouse model, those adverse effects are not that much noticeable, at least in our study.
Mhm. But do you know of any strategies to mitigate the side effects in humans?
So this is a proof of concept study. We can just use another senolytic agent like ficitin that we are using right now in our studies, or any other potent senolytic modification of ABT263. So there are approaches like PROTAC-based drug delivery approach um, has been developed by other investigators, where ABT263 can only be delivered specifically to the senescent cell, not to the like platelet or any other non-senescent cell. So in this PROTAC-based approach, what they do is this drug is basically tagged with a PROTAC, and that PROTAC is basically is a delivery tool that delivers this drug specifically to the senescent cell, not to the other cell. That basically can improve or reduce the side effect of ABT263 or any other that kind of drug where side effect is expected. So that kind of tool is already developed and being tested as a anti senescence therapy. So that kind of publication I have seen from like many groups. They have also modified ABT263 into a less potent version with less side effects. So
But I guess this tool also could help you to answer the question on to differentiate between SASP produced by senescent cells and SASP produced by tumor cells, because
yes.
targeting only
Yeah,
senescent cells, right?
yeah.
Great. Um, how is this drug used in combination with other uh, anti-tumorigenic therapies?
So We definitely need something which is much more safer than ABT263 or modification of ABT263 or a safer version of this drug or any other alternative. The whole purpose of this study is to demonstrate that senolytics can be used as a tool or as an intervention to reduce radiation-induced tumor risk or cancer development risk. So we have profiled several different senolytic agents in our lab, and a study is ongoing to develop which are safer and that doesn't require too much of FDA or other regulatory approvals. Like if we have a natural version of senolytic molecule like physitine, which is a flavonoid, with potent senolytic ability. I think that will be a better choice rather than using a drug which is known to cause thrombocytopenia.
Cool. And okay, how do you see this drugs to be applied to to the space area?
Yeah,
Like
so for
and
space, we do see all NASA-funded research not only on the radiation-induced cancer development, but we also do all kind of degenerative disease phenotype, particularly related to neurodegeneration and neuroinflammatory changes, which is very prevalent in during a space travel. So, senolytic is not only preventive in terms of cancer development, but we do see improvement in those parameters related to neuroinflammation, specifically involving SAS factors. We do see improvement after using senolytic approach. We have used like two different senolytic approach where we have a genetic model like ATAC mice where you can target senescent cell using ATAC cassette where you can induce death in P16 expressing cell using genetic approach. And we also saw using physitine and ABT263 that it improves not only the tumor risk as well as risk to the other degenerative phenotypes like neurodegeneration with and without space radiation exposure. So that is much more applicable not only for the cancer risk but for other risk type which is prevalent in space.
yeah, very interesting. Yeah, so my last question would be, what are the biggest unanswered questions for you in this field, and what are the next step you want to do?
Yeah, so our whole idea is to use the senolytic or senescence-based therapies. It is not only senolytic, but also senostatic or xenomorphic drugs, which can basically modify the profile of senescent cell and stop acquisition of SAS phenotype, and some sort of combination of both xenomorphic and senolytic to improve radiation induced late effects. So there are known late effects of radiation exposure, particularly in clinic where patients are treated with radiotherapy. In case of colon cancer, they do have rectal issues, fibrosis in the rectum and GI tissues. In case of lung fibrosis, mucositis in case of oral cancers. These are the known side effects of radiotherapy. Also, in case of chemotherapy, there are some kind of degenerative effects. So we are trying to develop senolytic based intervention, um, and even using advanced anti-senescence approach where we can identify a particular SAS phenotype which is driving tumorigenesis. For example, in case of GI cancer, we profile like 10 or 15 SAS factor, but not all of them are tumorigenic or driving carcinoma development. Only few of them are known to drive cancer development. So we can develop a monoclonal antibody-based neutralization approach where we can not only neutralize local SASP related to particular cancer type or carcinoma development, but we can dampen overall systemic and local SASP using these neutralizing antibodies and see if there is improvement in outcome. So we are testing xenomorphics. We are trying to combine it with senolytics. And in the end, based on personalized approach, like where each and every patient or subject can be tested for SASP profile and related to their SASP profile, let's say X or IL-6 is upregulated in that patient. We can just target that deleterious SASP phenotype to improve patient outcome, because not all SAS factors are deleterious. Only some SAS factors are related to cancer development or neurodegeneration or muscle loss. We don't need to target all the SAS phenotype for long time. We can use like approach based on the timing and profile of each and every individual in individualized way. So we can do profiling of SAS factors from patients from time to time and then address these phenotypes using a tailor-made SAS monoclonal neutralizing antibody approach to improve that kind of effect. So let's say like if somebody is getting treated for colorectal cancer and they got treated with all the standard chemotherapy agents, and after the therapy they see increase in one or two or three SAS phenotype which are deleterious or causative and prognostic factor for, let's say, secondary cancer development. So we can just target those factors which are related to secondary risk of chemotherapy instead of using all kind of different diagnostic and treatment based approach. We can only focus on those SAS factor and see if it improves a risk of secondary cancer development or not.
But
Because secondary cancer development is also a huge area where not much research has been done, particularly for screening and targeting.
and this could be done just using blood tests, right?
Yeah, so you can look into blood test using like proteomic profiling for targeted SAS panels. We can have a prognostic approach where we can relate SAS factor with the outcome of cancer therapy. And if it is related directly to the bad outcome, we can target that SASP using neutralizing antibody. So, and the beauty of neutralizing antibody approach is it doesn't require a normal um, drug approval pipeline. So, biologics has a very shorter regulatory pipeline for approval compared to having a chemical drug or a small molecule approach. And there are already bunch of SAS neutralizing antibody already approved. So depending on a person's profile, that antibody can even use or repurposed quickly.
Very exciting. Thank you very much for sharing your experience, and I wish you all the best with your research and hopefully
Thank you so much.
treat cancer sooner.
Yeah. Thank you.
Thank you. All the best.
Bye bye.